Welcome to Spotlight on Chronic Kidney Disease here on Hospital Radio for Bristol, where this time we look at clinical science and public involvement. Academic and chartered scientist Shahid Mohammed firstly explains what patient and public involvement, or PPI, is.
In 2014, the National Institute of Health Research, abbreviated as NIHR, they actually came out with this initiative introducing patient and public involvement through an effort known as Involve. So it was called NIHR Involve. It's absolutely important to involve members of the public who might have intrigues around different areas of healthcare. Nowadays, patient and public involvement is embedded in areas of clinical practice, and I would like to say it's embedded in laboratory science and laboratory practice as well.
Tell us about the science of nephrotoxicity.
Nephrotoxicity is really about where patients or individuals might be on multiple medications that can potentially lead to more renal dysfunction or renal insufficiency.
How does donor age matching benefit patient care?
Traditionally speaking, apart from blood group being absolutely important to get, then also on top of that is an age match. There was a paper published back in the late 90s, early 2000s by Nephrology, Dialysis and Transplant, and they talked about how age matching amongst donor and recipient was still a bit of a conundrum or an issue around then. It's got better over time, but this also, as you can appreciate, relates to whether clinicians on the front line are comfortable to ensure that age as well as the blood group is fitting to the recipient who might require a transplant.
What are the differences between live and choric organ donations?
Live donation is where patients who have family members worked up from a laboratory perspective and a transplant goes ahead where the clinicians and surgeons are happy for that to take place. A cadaveric, on the other hand, is where someone might have unfortunately passed away in, for example, a road traffic accident, and relatives have consented to having their family members' organs donated.
So, how can immunosuppression medicine be nephrotoxic and cause issues?
The main definition around immunosuppression is that they're known as anti-rejection treatment, and once an individual has a transplant, they have to have immunosuppression to prevent that organ rejecting from their body. The scientists also have a role in ensuring that immunosuppression and anti-rejection treatment are at the right levels when it comes to ensuring that clinicians give the correct dose so that it causes enough toxicity that the drug is working, but not so much so that it's going to cause nephrotoxicity, because then that would damage the kidneys.
Have scientists developed smarter ways surrounding therapeutic drug monitoring?
Laboratory practices have advanced over the years, and one of the main things is something known as high-performance liquid chromatography. What HPLC does is help laboratory scientists to get the right therapeutic window so when patients aren't getting enough of the immunosuppression they require, that's not going to cause nephrotoxic side effects and problems with a transplanted organ. But there are other advances in laboratory practice. For example, another one is something called Luminex technology when determining whether a transplant should go ahead or not. From a laboratory perspective, what Luminex technology does is basically an assay that is used to actually determine whether the memory cells from a previous transplant will affect the new transplant as well.
Finally, is there anything else that the Renal Patient Support Group would like to highlight regarding patient and public involvement?
One thing that has been happening in collaboration with the RPSG is Storm Lobostics. It's a production where lots of other audios and podcasts are being implemented to highlight healthcare sciences and academia and research and science.
Spotlight on kidney care here on Hospital Radio for Bristol with academic and chartered scientist Shahid